Welcome everyone to our first Public Health Voices webinar seminar of the new academic year. My name is Karen Mag. I'm a Senior Research Fellow in the Department of Behavioural Science and Health. We're very delighted to have you with us today. Public Health Voices is a webinar series open to all which aims to engage with and showcase the importance of interdisciplinarity in public health research and training. And this event is also part of the ESRC Festival of Social Science in 2023. And this year, a number of the festival's events will focus on lifelong well-being, exploring mental and physical health at all ages and celebrating the 75th anniversary of the NHS. You can find out more online by searching ESRC Festival of Social Science 2023. So today, we welcome Professor Daisy Fancourt, Director of the World Health Organization Collaborative Center on Arts and Health, for her presentation on how arts can support the treatment of mental illness and help to reduce the incidence and prevalence of mental health conditions. Professor Daisy Fancourt is Professor of Psychobiology and Epidemiology at University College London and head of the Social Behavioural Research Group. Her research focuses on the effects of social factors on health, including loneliness, social isolation, social and community access, arts and cultural engagement, and social prescribing. She's director of the World Health Organization Collaborative Center on Arts and Health, a technical advisor to the WHO, an expert and scientific advisor to UK governments, a BBC New Generation thinker, and a World Economic Forum global shaper. Thank you so much, Daisy, for joining us. So if you have any questions, please could I encourage you to submit your questions to the Slido link, which we will put in the chat. We will hold the Q&A session after Daisy's presentation has finished. Now I would like to hand over to Daisy for her presentation.
Thank you so much, Karen, and it is such a pleasure to be presenting today as part of this series. As you heard, I'm going to be talking about the role that the arts have within mental health care. The work that I do is as part of the Social Biobehavioural Research Group at UCL, and we look broadly at the impact of social connections and behaviours on our health, including social deficits like loneliness and isolation, and social assets like engagement with community factors, such as the arts. And we broadly try and understand what the relationship is between engagement with these different behaviours and the health outcomes that they can achieve, what the mechanisms of this are, who benefits most, and how we can change our social behaviours to achieve more of these benefits. And we do this via 4 different work streams that we run within the team. And today I'm going to be talking to you about the work that we've done across all 4 of these different work streams as it pertains to mental health. So to start with, what is the state of mental health in the UK? We face substantial mental health problems, and of course that's not going to be news to anybody. We know that around 1/5 of years live with disability worldwide are due to mental health problems, and the actual prevalence of mental health problems has been getting worse, in particular with problems that have arisen since COVID-19. But we're also aware that our approach to mental health is inadequate. We simply don't spend enough on mental health to tackle the challenges that are arising. This is a very small percent of the total NHS budget that gets spent each year. We also don't know who is experiencing mental health problems, and around 1 in 3 people with a mental health problem in the UK is thought to be undiagnosed. Our waiting lists are very long, so for example in child and adolescent mental health services at the moment, the lists can last up to a couple of years, and we know that 3/4 of people deteriorate whilst they're on waiting lists. And on top of this, many people actually don't receive treatment, and this is exacerbated by the fact that we've not been able to prioritise mental health adequately post-COVID. And part of the challenge with this is we simply don't have enough staff available to deal with this demand. So it's pretty clear that we need to do more. And this is where I think that the arts can be a really exciting thing for us to consider. So what I want to do today is to tell you a little bit about the work that we've been conducting over the last few years using clinical trials to address particular mental health conditions. And then I want to zoom out a little bit and think about at a population level how arts and cultural engagement could help with the prevention of mental ill health. And then I want to think a little bit more about the ingredients and mechanisms of the art, why we see these effects. And I'm going to close by talking a bit about social prescribing and the role that I think this can play in helping to address the mental health challenges we're facing as a health system. So first of all, what do I actually mean by the arts? The arts can include an extremely diverse range of activities, all of which tend to be united by the inclusion of creative, aesthetic, imaginative components. About 6 years ago, I was invited by the World Health Organization to publish a report trying to understand what the impact was from the existing studies. And in fact, we identified over 3,500 studies that have been published, looking at the role of the arts, both in the management of treatment of illness, but also in their earlier prevention and promotion. And this has been followed up since with a number of further publications with the World Health Organization, looking at what this means in terms of global development goals and thinking about how we can actually weave the arts into policies to try and support health and development. But I'm going to focus specifically on the findings that we've had in relation to mental health. So what's the impact of the arts engagement on mental illness? A few years ago, I worked on a trial where we decided to explore this, specifically looking at the intervention of djembe group drumming for people who had mild and moderate mental illness in the community. We had participants who joined workshops led by the Royal College of Music for 10 weeks. And across that time, we found that the drumming group relative to controls had significant improvements in a wide range of symptoms. So for example, by the end of 10 weeks, their anxiety levels were 20% lower than at the start. Their depression levels were 38% lower. And they'd also had increases of around 23% and 16% in their social resilience and well-being. What was really exciting about this study as well was that we followed people up 3 months after the end of the 10-week intervention, and we actually found that they'd maintained these results even though they didn't continue drumming in that time. And this gives us a little flavour of the fact that actually arts interventions might not just tackle things in the moment, but could actually help to activate mechanisms that could support the maintenance of positive mental health even when an intervention has ended. And I'm going to come back to these mechanisms later. We've also explored similar interventions in other populations. For example, I worked with an organisation called Tenefus in Wales, who were a cancer care organisation, and they, at the time, ran 25 choirs all across Wales for people affected by cancer, so people who were bereaved, people who were carers, and people who were patients. And we ran a series of studies with them, including one where we followed people up over 6 months of involvement as part of a programme with the Royal Marsden Hospitals in London and Surrey. And we found that the choir group actually had improvements in their well-being over this time, and also decreases in their anxiety levels. So again, seeing similar kinds of results to the broader community drumming interventions, but from a different kind of activity. And we've also been looking at singing in a lot more depth in a series of trials over the last few years focused on postnatal depression. We initially ran a randomised control trial in 2015 with the Royal College of Music and Imperial College London, where people were randomised into usual care for postnatal depression, which unfortunately doesn't consist of a lot, play, which was a 10-week programme of offering creative play sessions for mothers and their babies, as well as a singing programme, which was identical, but this time focused on music-based activities. And what we found was that the women in the singing session recovered around a month earlier from their postnatal depression compared to the women in either of the other two conditions. And these were all women who were above the threshold for severe postnatal depression at the beginning of the trial. This has been a really exciting project because we actually have been able to extend it with the World Health Organization and also as part of a trial called SHAPER. So SHAPER is a collaboration with King's College London, where we've been now embedding this trial within local clinical commissioning groups as part of their core programme. So it's been commissioned in a number of areas around London, and we've been conducting a larger trial looking at the impact in greater detail. Then with the World Health Organization, this is a project that's since been rolled out in Romania and Denmark and is looking to expand as well into Italy, Scotland and Greenland. So it's a nice example of how an intervention that tackles quite a complex problem, postnatal depression, which is very difficult to treat in new mothers, is actually something that can be delivered in communities for mothers and their babies and be achieving quite tangible results. So as an example from the original trial, we found that there had been a 40% decrease in depressive symptoms by 10 weeks, and this equated to 73% of the mothers no longer being classified as having postnatal depression within the singing group. These are just 3 examples of many programmes that are running all around the country looking at arts-based interventions for mental health. And over the last few years, I've been director of the March Network, which was one of UKRI's mental health research networks. This brought together over 2,000 researchers, community organisations, policymakers and healthcare professionals who were all trying to understand how social, cultural, and community assets could support mental health. And as part of the programme, we identified hundreds of examples of arts and mental health projects that were running all around the UK. On our website, you can see some fabulous case studies of these. And we also worked as a network to develop new research agendas, evidence reports, and policy briefings. This work has actually led to the seed funding of dozens of new research projects in the area, which we were able to seed fund through our UKRI grants. And collectively, this has now led to over £25 million of follow-on funding being received by March Network members for other projects. So really what this is starting to do is to move this concept of social, cultural, and community engagement for mental health actually into the mainstream of mental health research, such that it's receiving large grants, actually delivering as part of core care pathways, and achieving tangible impacts for different mental health outcomes. But all of this work so far has been focused in particular on the issue of management and treatment of mental health problems. And a few years ago, I became particularly conscious that we weren't really able to explore this issue of prevention in detail by using these approaches. So with a grant from the Wellcome Trust in 2017, I established a new programme of work that was looking at whether these social assets, these cultural behaviours, could help to prevent the incidence of mental ill health. So over the last 6 years, we've worked with now over 20 different cohort studies from around the world, exploring this relationship between arts engagement and mental health at a population level. This has resulted in over 100 papers that, of course, I can't summarise in detail in this presentation, but I wanted to pull out some of these core findings. And we have also just published a new report which synthesises all the findings, which I'll point you to at the end. One of the things that we explored was whether engagement with arts activities is associated with higher levels of well-being. And we looked both at participating in the arts as well as engaging in broader cultural things like going to museums or galleries or concerts or other kinds of live music events. What we found was that in a sample of 23,000 people followed up over 4 years, there was an association between both arts and cultural engagement and lower levels of mental distress and higher levels of mental functioning and life satisfaction. Now, naturally, the crucial question in all of this is whether this was a case of reverse causation. And so one of the things that, of course, we've done with all of these analyses is to map very comprehensively the factors that could be confounders in this relationship, including various different categories. And we've been modelling all of these into our results. And the results that we find are still independent of these factors. And I'm going to come back to this issue of these confounders and the methodological considerations in a moment. But I just want to talk through some of the other findings that we've had. One of the other things we looked at was whether arts and cultural engagement was also associated with a lower incidence rate of depression. So in a study using the English longitudinal study of ageing, we analysed data from just over 2,000 adults over the age of 50 who had no diagnosis of depression and no past history of depression, and also weren't currently exhibiting any symptoms of depression. And we looked at what happens over the next 10 years for these individuals. As you can see, there was this nice dose-response relationship where the more activities they were doing that were cultural, so going to museums, cinemas, the theatre, concerts, etc., the lower the incidence rates for depression over that decade. And once we'd adjusted for confounders, we found that this equated to nearly half odds of developing depression in that follow-up if people were engaged once a month or more. This isn't related just to adults either. In a study of children, we looked at children aged 7 who were considered behaviourally settled by their teachers at school, and we followed them across 5 years. We found those who were more engaged in creative activities and demonstrating higher levels of creativity in things like painting, dancing, music, etc., had a lower risk of developing internalizing behaviours, including depression, as well as broader behavioural problems. So, of course, this brings us to the issue of methods. How can we really be sure about whether this is some kind of causal effect that could be coming from arts and cultural engagements? Now, naturally, with observational data, that's always going to be a question. But there are a number of things that we've been exploring in our work over the last few years to really tease this apart. The first of these is considering the kinds of factors that can be confounders. And of course, this is extremely broad when we're considering an activity like arts, which is, of course, a social behaviour which brings a lot of social patterning with it, as well as something like mental health that we also know is socially patterned. So, for example, we found that there are various demographic and socioeconomic and health-related factors, but we also have to consider things like other behaviours that people might be engaging in, the areas, the geography of where they live, and how this can affect participation. As well as generational factors, we know that parental engagement in the arts and the exposure in early life to the arts can also be independent factors affecting people's subsequent arts engagement. One of the ways that we've explored this is to try and understand what percentage of associations are explained by these various confounders. So as an example here, this is a study that we actually looked at in mortality that we published in the BMJ. We actually tried to ascertain how much of the association between arts and mortality rates was explained by people's arts and cultural engagements. And overall, about 40% of the association was explained, and we can see how this was parsed out between these different explanatory factors. But crucially, we are still finding that there are independent associations, even when this broad range of factors have been coming into play. Nonetheless, the issue around socioeconomic status is a really crucial one that we've done further exploration into, because we know that this social gradient is quite strong in cultural engagement. I'm going to show just how strong later on. But this gradient can also be partly due to logistical factors, so proximity and access to the natural and built environment, higher levels of disposable income, socialization. We know that people from higher socioeconomic backgrounds are more likely to be exposed to cultural activities. And also we know that some of this can be due to differences that are then evident, for example, via educational pathways as a result of exposure to arts and culture. So it's actually even possible that arts and cultural engagement could be related to or even play a role in increasing health inequalities. If we're arguing that this is a health behaviour that can affect health outcomes, then the uneven distribution of this could actually be more of a public health concern. So one of the things that we've explored in particular is whether the relationship between cultural engagement and depression genuinely does seem to be independent of socioeconomic status. And in one of the papers, we tested this by using a whole range of different statistical methods. We took individuals who were free from depression, and first of all, we ran a standard regression adjustment. So we were looking at the odds of experiencing depression over a 12-year follow-up, whilst adjusting for socioeconomic status and broader demographic factors. And as I showed in our previous graph, there was an association. But we're aware that logistic regression models can still result in residual imbalance between groups that can bias the results. So in a second approach, we then looked at further stratification, where we tried to see, is the same result still actually present, even if we start to look at subgroups of this? And interestingly, we found that even in those of higher and lower wealth or education, this relationship was still coming through. Nonetheless, to take it even further, what we then did was a technique called propensity score matching, which essentially tries to imagine a randomized control trial that we would never actually get the full ethical approval to conduct. So essentially, we imagined taking 2,500 adults who did not have depression, but were regularly engaged in cultural activities, and finding them a matched twin. So someone who also didn't have depression, but was not engaged in cultural activities. So these two groups were found to be pretty much identical on all the other factors, particularly the socioeconomic factors, as you can see from this graph here. So these black dots show the two groups before we did any matching. And you can see the further things are from this straight line, the less matched the groups are. But following our matching, we were able to achieve a nice balance between the groups. And we followed these people up over the next decade. And again, even when we'd been applying this approach, we were still finding that there was a significant association, a very similar effect size from these analyses. Nonetheless, we are at this point still relying on a different methodological problem, which is whether we've actually identified all the different socioeconomic factors that could bias results. We know that socioeconomic status can be present in a vast range of quite subtle different factors. So we then ran a different analysis, which was fixed effects analysis, which is really clever because it compares individuals with themselves over time. So essentially you become your own control. And this means that anything that's stable about you over time gets almost cancelled out from the analyses. It means it's factored in even without having to actually specify what it is. So things like socioeconomic status can be relatively stable, particularly for the older adults that we were working with. But it also gave us a chance to look at other stable factors. So past medical history is in the past, it's stable. equally certain genetic factors or other biological factors or aspects relating to past arts engagement, such as childhood arts engagement. All of these will be automatically taken into account. So the question is whether if we see a change in people's arts and cultural engagement, is that followed by a subsequent change in their mental health? And indeed, this is what we still found. So in other words, what we're seeing is that regardless of the statistical approach, if we apply techniques that essentially triangulate findings from lots of different statistical methods, we still seem to be converging on similar findings. It doesn't mean that we've completely got rid of the issue of socioeconomic confounding here, but it means we've given a really strong attempt at demonstrating that it's not the core cause of these relationships. And just as an example, this was the graph from the propensity score matching, where you can see there was still an 18% lower odds of developing depression in the group that was culturally engaged compared to not culturally engaged. There is, however, a further issue that we identified, and this was one of ecological validity. So the studies that had been conducted over time, such as ours, had focused on a single country. Now, what's interesting is that since we published our first studies on this, there have actually been similar studies that have tried to copy our approach using data sets from different countries, such as Scandinavia. And promisingly, they found the same results using these different cohorts. But nonetheless, there can be differences in definitions or outcome measures or methodological approaches between studies that could lead to spurious findings. And it's still not completely clear if results could extrapolate to countries that have quite different cultural settings or potentially different patterns of valuing the arts or different patterns of socioeconomic gradients in arts participation. Not to mention the fact there could be potential cohort effects in the studies we've been using. There also hasn't been work looking at whether macro level factors, so like country level factors, could moderate results. Are the results found in countries that have better or worse health outcomes, for example, or higher or lower levels of inequalities? Nonetheless, there are some very intriguing evolutionary anthropological theories about the potential benefit impact of the arts for species survival that I won't go into in detail, but nonetheless suggest from other lenses that there could likely to be benefits across different populations. So this is something that we decided we really wanted to test a couple of years ago. So actually with Karen, who introduced me for this talk, and some other colleagues in my group and internationally, we decided to synthesize the findings from 16 different cohort studies around the world. So this led us to a sample size of 94,000 people. And we then conducted a whole series of analyses trying to understand if this relationship between arts engagement and a wide range of mental health outcomes is present. What we then did is we then looked and meta-analysed our own findings to see whether there was evidence of an overall effect when we pooled all of the data together. So this paper, which has just been published in Nature Medicine, showed that there was actually quite a variety of participation rates between countries. So, for example, only 51% of Spanish respondents reported engaging in hobbies. And this was specifically the variable we were looking at was hobbies, so creative or artistic activities that people do in their spare time. But in contrast to 1 in 2 people in Spain, it was 96% of people in Denmark. So it's a nice spread between countries where it was a very prevalent or less prevalent activity. And we now actually have subsequent work going on where we're trying to map specifically what the levels of inequality and engagement are between these countries. But as you can see, across all of these outcomes, we were finding that when we pooled the results together in a meta-analysis, there were overall effects showing associations longitudinally between hobby engagement and depression, self-reported health, happiness, and life satisfaction. Crucially, we've actually found these are not just cross-sectional, but they're also longitudinal. In our paper, we ran a number of different types of analysis to really test the strength of what could potentially be a directional effect. The other thing that we looked at was this issue of whether country factors could moderate the relationship. So to ascertain how much of the variance in this relationship between mental health and hobbies was explained by country, we merged the data sets and ran multi-level models. And even when adjusting for confounders, we were then able to see what percentage of the variance was explained by these country level factors. In other words, how much does this a standard finding across different populations, or how much is it due to variations in different country settings? Interestingly, the percentage was very small. Less than 9% of the total variance was explained by these country level factors. We did find there was a slight correlation between country levels of happiness, life expectancy, inequalities, and wealth levels. So you can see here there was this relationship between how much, what the prevalence of hobby engagement was in these countries and these various different factors. But the relationship, was slightly stronger in countries that had better self-reported health and slightly better life satisfaction. But the effect was actually minimal. In other words, this relationship does actually seem to hold true even in different ecological settings. A final issue just to be aware of is the issue of definition and choice and personality and identity in this. It's challenging to standardize effects when there is heterogeneity in terms of the types of activities that people do and how we categorize them. Often people who are doing one kind of arts activity are actually involved in others as well. And we know that arts activity can be influenced by existing health problems, including potential prodromal symptoms. There are also issues to think about in terms of social psychological approaches, which have said that individuals only really experience benefits if they really identify with the group or activity that they're involved with. And we also know that these activities can occur within their community context, and therefore the community context can really influence how people engage and what the impact of that engagement is on their health. So really this actually starts to move us into much more complex ground. If we're really trying to argue for some kind of association between arts engagement and cultural engagement and health outcomes, there's a lot of heterogeneity that we have to start being aware of in terms of the individuals who engage, the activities they're engaging in, and the context of both of those things. So a few years ago, we decided that we had to start exploring this theoretically in much more detail. And this has led us to think much more about complexity science. We're arguing that these are all complex phenomena, the activities, the people, and the contexts. So we have to have much better frameworks and language to understand what that complexity is. So I want to start thinking about how it is that the arts could affect our mental health. And I want to consider ingredients and mechanisms. The concept of active ingredients is one that's come from pharmacology initially, identifying what the active ingredients in drugs are for achieving their treatment effects. But it's been applied quite strongly now into behavioural science. And we published a paper a few years ago where we then tried to apply it specifically into understanding arts. Our argument is that arts activities are comprised of, we've identified, over 130 different active ingredients. Now, these aren't every single ingredient in the arts, but they're the active ones that we consider have the potential to impact health outcomes. And in a new framework that we published, we've separated these out into things relating to the project itself, or the activity people are doing, as well as the people that people interact with in that activity or come into contact with, and the context that that's taking place, both in terms of the setting or how people are being referred. Are they just choosing to do an activity, or is there some kind of official signposting or referral going on? If we think about this ingredient approach, it actually gives us a language to start comparing different kinds of activities. So, for example, if we're imagining a running club and a community choir, these things actually have quite a lot in common. They're both activities that are regular with a structured format. They provide sensory stimulation. There are some shared physical motions like deep breathing. They also provide opportunities for social exchange and social mixing and a supportive atmosphere. Similarly, there are certain shared ingredients we start to see from arts activities like, say, a book club, and formal mental health support like CBT. For example, in a book club and CBT, we're both focused on cognitive stimulation, working through emotional states. There are examples of behavioural modelling and exposure to social stimuli and mindful experiences too. So the arts can be a vehicle essentially for achieving ingredients that are found in other better accepted health behaviours. But the arts also have something that I think is particularly special, and these are the aesthetic ingredients that they bring. The arts are intensely sensory experiences. They also provide opportunities for imagination and creativity, and they can bring people into contact with cultural environments. They're also particularly strong at getting people to engage because they are leisure activities rather than formal medical treatments. So this gives them some added benefits that can help to start thinking about how they're achieving treatment effects. So then the next question is, if we've got these various ingredients in arts activities, what are the mechanisms that are then linking them to mental and other physical health outcomes? We published a paper in the Lancet Psychiatry a few years ago where we did a mapping of all of the different ingredients that have been identified, and we found over 600 in total. And we categorize these into various different processes, so psychological, biological, social, and behavioural. And crucially as well, we showed that these mechanisms don't just exist at an individual level, they can also exist at group and societal levels. For example, if I were to join a choir, that might help me to stop feeling so lonely as a group activity, but that could also provide opportunities for group bonding for other members of the activity too. And if you had enough choirs within a community, you could start to imagine that this could support things like social cohesion at a societal level. So we have to think carefully about the different micro, meso, and macro levels at which these mechanisms can occur. I'm only going to go through a few example mechanisms now, but I wanted to touch on some that I thought could be particularly important for mental health in explaining some of the results that I presented from the trials and epidemiology work. Where in terms of psychological mechanisms, we identified a broad range in our Lancet Psychiatry review that can start to explain these effects, including the arts helping to support the development of psychological capabilities like emotional learning, psychological resources, a sense of self and identity, as an opportunity for developing meaning and autonomy, a way of helping to regulate emotions and support coping, and also building resilience and personal transformation and growth. As an example, in a study that we ran with the BBC, we did a citizen science experiment involving 100,000 people, and we looked at how people use arts activities to regulate their emotions, identifying 3 different categories: the use of the arts to help avoid negative emotions, to help approach emotions with strategies such as problem solving or reappraisal or discharge, and also building a sense of self so that people felt more capable of tackling challenges in their lives. We've also shown, for example, in the choir study that I mentioned earlier, that one of the core mechanisms was building resilience to be able to deal with the mental health challenges that people were facing. Similarly, to try and understand the effect of cultural activities on health, we've identified that purpose is a really important factor here. People who have a strong sense of purpose are more likely to engage in cultural activities, but we also found that a sense of purpose, engagement in cultural activities can lead to an increased sense of purpose in individuals. In terms of the biological mechanisms, one of the things that's been shown quite strongly and interestingly is research that's looked at dopamine release in the brain, showing that actually arts activities can lead to an increase in dopamine release, not just from the actual experience, but also the anticipation of the experience via 2 different parts of the dopamine reward pathway. We've also looked at other kinds of biological pathways that could explain these results, including looking at inflammatory markers. In this study, using cultural engagement and the English longitudinal study of aging, we showed that people who are more engaged in culture and other community activities actually had better levels of inflammation regulation compared to people who weren't engaged in these activities. And we've taken this further in other studies. In the drumming study that I mentioned earlier, we found that there were decreases in people's stress hormones across just a single session of drumming. And we've replicated this since, for example, with people going to concerts, being able to show decreases in glucocorticoid activity and also in the ratio of glucocorticoids to other types of stress hormones, including dehydroepiandrosterone. And in the choir study that I mentioned earlier as well, the biological factors seem to be important too. For example, we found that in all participants, there was a decrease in cortisol levels across just a single session of choir singing, alongside increases in a broad range of other biological markers, especially cytokines. What's particularly interesting here is that whilst this overall pattern of biological activation just suggests a sort of broad cytokine network activation, when we started to look at the ratio between pro and anti-inflammatory markers, we found there was actually a shift across the choir singing from a higher ratio of pro-inflammatory to a higher ratio of anti-inflammatory cytokines. And this is really important because cytokines are implicated in mood and also in broader mental health. So higher levels of inflammatory markers are associated with higher levels of depression, for example. So seeing this shift towards a lower inflammatory profile from a session of singing suggested this could be one of the other biological pathways that link arts activities with mental health outcomes. Similarly, in terms of social and behavioural mechanisms, there are a broad range of things that could actually help to explain how the arts lead to increased levels of social bonding, improved social learning, and increased social resources like social capital, as well as the arts actually helping in the development of broader behavioural activation. So, for example, if people are going to arts activities regularly, that can help them to form new habits. It gives them disruption to existing habits that might not be so healthy. It also activates them in terms of making behavioural decisions. It can improve motivation or sense of achievement. And we've actually explored this specifically in some of the studies. For example, in the drumming programme that I mentioned earlier, we found that the mutuality was a really crucial mechanism in the support and supporting the outcomes that were achieved. So the sense of connecting, belonging, and accepting and socializing that people had through the groups. Similarly, in the postnatal depression trial, we found that singing specifically led to a greater increase in mother-infant bonding than we found from play activities. So we were able to directly compare the singing and play and show that the singing seemed to be what was particularly crucial there. And in fact, because this was a 3-armed trial, as you may remember, we were able to compare the singing and the play groups across the 10 weeks for other kinds of mechanisms. The blue things here show the mechanisms that were common to both singing and play, but there were some in pink that were unique to the singing, including this bonding, but also factors like providing opportunities for achievement and purpose that the mothers felt was particularly crucial to their well-being. So these are just a smattering of some of the mechanisms that we've been starting to explore. But of course, the crucial question that then comes up from this is, if we've got certain patterns of ingredients and mechanisms, if we've got this framework that comes, how can we use this to actually compare across trials? And increasingly what we're trying to do now is to be able to use these different frameworks to identify what is different about certain arts interventions from others. It makes sense that certain activities might work for a broad range of health outcomes, but then there are other situations, particularly when we start to deal with specific types of mental illness and severe mental illness, when actually certain ingredients may be more or less appropriate. So, for example, in the postnatal depression trial, the fact that it was a trial that involved mothers specifically with postnatal depression was one of the things that came through as crucial to the outcomes, because the mothers felt that it was a safe space, whereas they'd already been put off sometimes from attending activities for women who weren't experiencing postnatal depression. So these kinds of ingredients, we can start to identify those that are most crucial to achieving treatment effects, and hopefully with these frameworks have a more systematic approach for comparing between trials and showing why some trials worked and others didn't. One of the other things that we're now looking at in a lot of detail too is the effect of moderators, so understanding why certain individuals might benefit more than others. Because this is a complex intervention with multiple different ingredients and mechanisms, we have to accept that there can be different effects on individuals. And this is challenging sometimes from a research design perspective to ensure that we're actually able to capture the full range of outcomes and be able to tell if there are indications of overall effects that could suggest being beneficial to other populations too. But these kinds of frameworks and tools are extremely helpful for having that kind of rigor when we're moving forwards with these complex studies. But finally, I want to turn to quite a crucial issue in this, because if we're arguing that arts and cultural engagement could have a tangible impact for mental health and well-being, then one of the things we have to consider is, can everyone actually benefit from arts engagement? And what we know, unfortunately, is there are inequalities in community engagement due to a range of factors. For example, by demographics, as I mentioned earlier, we do find that there is a strong social gradient across this, both in terms of performing arts, literary arts, cultural activities. Similarly, we know that geographical factors can actually make quite a big impact too. In analyses that Karen and I ran, we found that if we took people living in deprived and less deprived areas, even once we'd accounted for individual socioeconomic factors, there was a clear marked difference in terms of people's engagement, with lower engagement in more deprived areas compared to less deprived areas. And interestingly, this wasn't just for factors, for types of engagement that depend on tangible assets like museums and heritage sites. We were also even seeing it for broader arts participation, which can, of course, be home-based. We also, unfortunately, see that there is a social gradient based on mental health. We find that people with higher levels of depression and lower levels of well-being are less likely to engage in arts activities. And we've identified that some of these factors can be due to opportunities. So, for example, issues around accessibility and affordability, but it can also be due to perceptions that perhaps someone doesn't have the right skills to engage or the right psychological traits. So some of these are barriers that need to be addressed in quite different ways. On top of this, we're also facing major funding cuts and deprioritisation of the arts within the UK. So, for example, grants to museums and galleries halved over the past decade. There have been significant drops in the number of pupils who are studying arts-based subjects. And we've also been seeing substantial closure, for example, the loss of nearly half of our libraries around the UK. So these are big challenges to deal with in terms of having the assets to be able to deliver arts and cultural activities. Nonetheless, there are some promising schemes that are attempting to ensure that people engage, particularly those who might not typically engage in arts and culture. And one of the ones I wanted to end by mentioning is social prescribing. I'm sure this is something that everybody's heard of recently because it's become quite a buzzword, the idea that we can refer people to non-clinical services within the community to support with a broad range of both clinical and non-clinical problems. Social prescribing is now happening in countries all around the world. And in fact, my team and I are working not just on studies in the UK, but across Europe and major pilots across the US at the moment as well. But essentially, even if the model differs slightly in different places, it consists of individuals being referred either by a GP or by another health professional through to a broad range of activities, including learning and skills development, community employment supports, and different community activities, of which arts and culture are just some of the offering. Social prescribing was announced as being rolled out in the NHS about 4 or 5 years ago, but there's actually been a commitment now to substantially increase the number of link workers. These are the people who link patients through to suitable community activities. And one of the areas of focus is mental health. The early analyses on this have suggested there can be benefits for the health service as a whole, but we've actually been undertaking more work as well to understand the impact on the individual. One of the things that we've looked at is whether there is any signs that social prescribing could help the arts to people to access the arts who wouldn't normally be able to. And when we look at issues of equality, we found in 2 separate analyses using both electronic patient records and also data from a platform called Elemental, which is a private platform that's used to track social prescribing across both GPs, but also community organisations as well. And we have found that social prescribing is actually reaching people from more deprived areas most, particularly across England, Wales and Northern Ireland. And we've also identified that it is reaching some of the people who arguably should be the ones benefiting most, like people with more long-term conditions, making more use of primary care. So we've been conducting a number of trials to actually look at the impact of social prescribing. One of the ones that we are currently leading on is called Inspire, and it's focusing on child and adolescent mental health services, integrating social prescribing whilst young people are on the waiting list, to see whether providing this on waiting lists not only helps to potentially reduce levels of deterioration, but could actually support broader mental health outcomes and enhanced individual and social well-being as well. We've also got other projects that we're currently exploring, both bringing this to different populations like people with severe mental illness and also bringing it to other settings such as in education. So in summary, we know that there is a crisis around mental health care in the UK, but arts and cultural engagement can provide tangible and measurable effects on our mental health, as I've shown both through the trials that have been conducted and also the epidemiological studies now coming out. We are getting much better now at identifying and being able to describe the complex ingredients and mechanisms that actually enable these effects to be achieved. But it feels like we're fighting a bit of an uphill battle because at the same time that we're demonstrating the impacts of these assets for our mental health, we're also seeing that engagement is not equal and the opportunities for engagement are being eroded. So I think it's really crucial that we think about how we can be using this pretty remarkable asset to be supporting mental health. We actually did an audit where we identified over 1 million cultural assets in communities in the UK that are currently available for people to engage with. And I think it's crucial that we help people to reach those different programmes and settings. So social prescribing is a novel and evidence-based way that we can help to achieve this. So moving forwards, I think it's vital that we have more research that starts to elucidate even further how and to what extent the arts can impact on our mental health. And I think that as we're facing all the challenges that are addressing health services in terms of their treatment of mental health, considering these broader community options such as the arts, and via schemes such as social prescribing, is a really sensible and exciting route to be pursuing. I'd just like to end by saying that this has been a bit of a whistle-stop tour, but if you're interested in reading more, we recently published our Impact of Arts and Cultural Engagement on Population Health report, which synthesises the findings from nearly 100 epidemiological studies that we published in this area. We've also published a specific guide around how to improve access to the arts for people with mental illness. And on our website, you can find more details about all of the projects that we currently have running. And there's a newsletter if you'd like to sign up and find out more about all of our work. Thank you so much.
Thank you so much, Daisy, for giving such an exciting and comprehensive presentation. So we have a few questions from our audience, and we would love to hear your thoughts. So the first question that we have is that what role would you say arts engagement has in building up cognitive reserve and preventing cognitive decline or brain aging as we get older?
This is a really interesting topic. We published a few papers on this over the years where we've looked at things like cultural engagement and arts participation in relation to cognitive function in older adults. In some analyses, we've shown that there are associations with a slower decline in cognitive function as people age and better preservation of things like memory and executive function. And we've also looked specifically at dementia diagnoses using combinations of self-reported diagnoses by physicians, as well as people's scores on complex cognitive batteries that assess dementia, as well as people's hospital records. And we have found associations between cultural engagement and lower incidence of dementia, and also a longer time to onset of dementia as well. Now, all of these have adjusted for all of the kinds of confounders we'd expect. But of course, a key challenge with dementia is that the prodromal effects can be happening for 20 or so years before a diagnosis actually occurs. So to date, the longest time span we've had is about 14 years in our follow-up, but we're just waiting on the release of more data that would allow us to look at this over more of a 20-year span. And I think it'll be really interesting to see whether those associations are maintained over that longer period that might start to move us slightly beyond the envelope of prodromal effects. There have been studies from other countries that have replicated our findings in other samples as well, but there's still some debate about that prodromal effect that I'm really excited for us to explore more over the next couple of years.
That's really wonderful. Thank you so much. So the second question that we have for you is that when it comes to singing, would you say that improves mental health because it activates or stimulates the vagus nerve?
The vagus nerve, that is one of the mechanisms that has been explored and has been suggested. In fact, there's broader research that's looked at autonomic nervous system alongside other biological pathways. I'd say that given that we know there are so many mechanisms involved, it might be one mechanism, but it doesn't mean that it's the only mechanism. And I think we have to make sure that if we're specifying certain mechanisms, it's still within the context of that much broader psychological, biological, social and behavioural framework of other mechanisms that are likely coming into play as well.
Wonderful, thank you. And how could health and social care services could better use arts, drama and music therapies to provide better holistic prevention, support and treatment?
I think one thing we have to be quite clear on is the distinction between arts therapies and broader arts engagement. So arts therapies are those that are typically defined as being led by a trained therapist, psychotherapist, and those are distinct from programs that might be delivered by artists who don't have any formal training. Now, often those activities have a number of shared ingredients, so they can actually be very, very similar for the individual, but some of them, so the therapies can also involve much more specific therapeutic components, often those that mimic things like CBT, for example. This means that we often see the therapies being applied specifically in things like severe mental illness. So I think if we're thinking about how we could integrate the arts into these clinical services more, the first thing is to identify what the population groups are and which approach is best. So for severe mental illness, it does make sense to have people who are particularly trained on working with certain patient groups and also who understand the medical histories of the individuals who they're working with. And that's also the case for things in inpatient settings often. But then if we're looking at broader populations of people who might be living in the community with diagnoses of depression or generalized anxiety disorder, for example, then those are individuals where actually broader kinds of arts engagement could have additional benefits, like the fact that they are already integrated into community provision. They're not as medical, they might not necessarily carry the medical label that could be associated with stigma. And if people are not wanting to engage in medical treatments, then they provide a different alternative option for them. Schemes like social prescribing are obviously existing pathways that can help people to be referred to those activities. But there are also some really interesting other models. Sometimes we're finding that within primary care, settings have got their own activities actually run on site. So Bromley by Bow, for example, has got things directly running in right next to GPs, so people can be directly referred through. And in other cases, we're finding programs that are being run by arts organisations themselves within the community. So, for example, within libraries, there could be programs that are already running, which are then either recruiting people themselves or are partnering with health services so that they can signpost people through. So sometimes they're formal referrals, but sometimes it's more of a signposting to things that are available for people to participate in. And I think we need to have that breadth of offering because we're dealing with a very broad range of mental health conditions and a broad range of different type of people as well. So that comes back to that identity approach, trying to find routes that people will feel are right for them, as well as activities that match what they're interested in.
That's nice. It's very nice to hear that the healthcare system is getting more integrated, not just within the primary care in hospitals or clinical settings, but also with the community settings. So there's another question that is quite related to it, is that how to best approach dosing for arts prescribing, for example, frequency, duration, optimal mode of arts based on available data.
Sorry, the question was
how to best approach dosing for arts prescribing, based on available data.
To be honest, the length of trials of arts interventions in the past hasn't been the most scientifically determined. I know this because we were looking into it a few years ago to try and justify how long we should make the interventions for things like the postnatal depression singing program. And there seems to be an array of things from sort of 6 to 12 weeks as being a standard initial amount. I know that sometimes mimics the length of certain psychological therapies that people can receive, but it doesn't necessarily mean that there is an optimum number within that. One of the things that we have found fairly consistently is that you can see effects in short periods like 6 weeks, as we saw in the postnatal depression project. Often the speed of these effects then slows down after about that first 6 weeks, but it seems to continue improving, and arguably what you're seeing then is more of a consolidation effect. What we don't yet have the data on is to know, well, how many weeks would you have to do something in order to have a follow-up of a certain amount of time? And often the follow-ups are the things that aren't done as much in research studies, because having that extra 3 or 6 months on interventions to be able to look at the maintenance of effects isn't necessarily as easy to come by in terms of funding. But this is where the framework of ingredients starts to be really interesting, because although the number of studies at the moment precludes us being able to make concrete comments on what length is best, the more studies we start to build up, the sooner we'll get to a point where we can start identifying that X number of weeks tends to be associated with maintenance effects of a further X number of months, for example. But given the complexity of that, it's always going to be a challenge to specify a particular magical amount. And I don't think there is going to be X number of weeks or frequency of dosing that's going to be correct. I think that would be starting to take us more towards a biomedical model. And the whole point of this is it's a complexity science model we should really be taking instead. So I think a stronger approach is to consider the patient group and the kinds of outcomes that we want to achieve. Essentially, we want to keep people engaged for as long as possible. Sometimes that means through a set number of weeks engagement to start off with, followed by a more informal signposting people to further opportunities where they might then be able to continue consolidating the benefits they might have had from a shorter intervention.
It's lovely to know. Thank you. So another question that's also related to is, will an increase in funding for community projects alongside the increase in social prescribers by the NHS? It's important to build capacity for the programme.
I very much agree, but unfortunately, it's not something that seems to be happening at the moment. So this is a huge challenge when we're dealing with something that essentially crosses government budgets. So there are lots of the funding that's come for social prescribing has specifically funded the link workers who do the referrals, but that doesn't mean that it's come to fund the projects themselves. So we have got some clinical commissioning groups that have been quite groundbreaking in terms of actually putting money forward themselves for the interventions, recognising that the benefits will come back full circle to them. but this isn't something that always happens routinely at the moment by any means. So then the next issue is whether arts are funding this. And we have definitely seen an increase in this kind of work being funded by funders such as arts councils. But it's still, it wouldn't necessarily be fair if this became their core output in terms of providing activities for people to be referred to by the health service, because there's a much broader amount of arts and culture that's provided for people's day-to-day enjoyments. I guess what you would hope is that there would be sufficient funding that the day-to-day enjoyment is available for everybody, and you can also have bespoke programs that target particular patient groups who might need different types or more high level intensity of support. But this is the ongoing issue at the moment, is that the funding simply isn't available for that from the arts side or the health side. So I think all the situation right now is to make sure that if the evidence base is suggesting benefits, that we're being very clear of what these benefits are, how big they are, and therefore why it's important to have higher levels of funding into these activities.
Thank you. So we have quite a lot of questions coming in, but I guess we have some time to answer one more question, perhaps. So what proportion of the evidence is from low and middle income countries and among ethnically diverse groups or homogeneous ethnic groups who are marginalized?
A lot of the work has so far come from at least Northern Hemisphere countries, seems to be the general pattern, although we have seen a number of studies that are coming through from low-income Northern Hemisphere countries as well. But there is increasing work that's trying to look at this in other ways. So, for example, the work that you and I have been doing, Karen, we've been increasingly getting access to cohort studies that include low and middle income countries so that we can include them in the broader multinational analyses and ascertain whether there is any difference of effect. And that's something we're currently working on for a new commission with the Lancet, where we're looking at barriers to access in different continents across a low and high income and northern and southern hemisphere countries. At the same time, the World Health Organization, through our partnership with them, we've been doing specific work on this, for example, taking the postnatal depression study into Romania to look at this within more deprived communities, as well as rolling it out into higher income countries at the same time. There is also interesting work that is coming out led by lower and middle income countries themselves, but often this has been of smaller pilot studies rather than the resources to run much larger clinical trials. But I think there's hope that there'll be more of that, particularly through grant funding that allows things to operate in multiple countries at once, which seems a good model for starting to develop and translate the expertise that's been developed in places like the UK, but be able to take that and to learn from that and support it on other projects in other countries.
That's lovely to hear. Thank you so much. So we'd love to say thank you, Daisy, again, for giving such an exciting and inspiring presentation. And it's also great to see that not only how the arts can prevent mental ill health and improve mental health, both nationally and globally, but also why we're seeing the benefits and who are more likely to enjoy the benefits from the arts. I would also like to thank our audience for joining us. It was lovely to see many of you here today. Please do sign up for the next event in the series, Who is a Humanitarian in 2023, which will take place in November.